Uh, it's Joe Reisman here. A great pleasure to be with you this February morning to introduce Dr. Thierry Daboval and his talk entitled Cord Gas to Screen for Hypothermia Treatment in Neonatology. It's with great pleasure I introduce Dr. Daboval. He joined the Department of Pediatrics at CHIO in 2006. He is currently at the rank of associate professor. Thierry has a variety of interests in neonatology, including issues surrounding neonatal follow-up and following high at-risk kids for their neonatal and then infant development. He is interested in medical ethics as it applies to the neonatal intensive care unit setting. And he has an interest in looking after newborns at high risk for hypoxic ischemic encephalopathy. In addition to interests in neonatology, Dr. Daboval has advanced belts in self-defense. So if you're going to argue with him, make sure you stay your social distance. Please join me in welcoming Dr. Daboval for this morning's CHIO University of Ottawa Grand Rounds. Take it away, Thierry.
Yeah, thank you, Joe. That was, I didn't remember that you remember about this. Yeah, black belt. So thank you, Joe. Thank you. Just wanted to thank my department for having me this morning and for this opportunity to have colleagues, obstetrician, neonatologist, pediatrician, and collaborators, future collaborators to listen to this, what I found interesting topic, and I hope you will find it interesting as well. So this part of my this part of my career started about 5 years ago when I got attracted by Claude, who joined in the audience today, and Paul, also I think he's in the audience today, to this, what I found, I told you, very interesting topic, and they raised my interest to better understand cord gas and how to use it for me as a neonatologist to better screen babies for hypoxic ischemic encephalopathy. And I learned so much that I felt the need to share with you what I learned, and I hope you will find it interesting, because it is interesting, but the, nope. Okay, there. So, I mean, when I started to look into this and when I got invited by my friends, my first reaction was, what? Cord gas? Something new, really? And maybe you feel that when you had that kind of reaction when you saw the title of my talk today. But this reaction could be well explained by some good reasons. And in fact, it's maybe explained by the historical context, because cord gas analysis was developed many years ago, a long time ago. And in first, it was described by James in 1958 to assess the acid-base status in infant in relation to birth asphyxia. And we didn't participate to the debates between two schools, the Copenhagen and Boston, in the two systems to interpret acid-base and their different point of view. And so what we learn in medical school nowadays, we don't necessarily be aware of this different point of view, and which are not reconciled, in fact. And we take for granted, and most of us will take for granted what we are receiving from the laboratory when we look at the pH, PCO2, PO2, but especially like the bicarbonates and the base excess calculation. And so I hope during this presentation you will understand a little bit better what I learned over the years of doing this research. So the clinical context and the problem that we're addressing in this presentation is obviously the hypoxic ischemic encephalopathy. And HIE is the most common neurological complication in neonatology. The incidence is still, we are lucky, low, between 1 and 6 babies per 1,000 births in developed countries. And it is associated with an increased risk of neurodevelopmental disability, including cerebral palsy, but also other developmental concerns as well. And cord gas values, especially the pH and base deficit, are mainly used by official bodies to help to identify these babies at higher risk of HIE and to assess the acid-base status at birth and help to determine the likelihood of long-term complication. Now, as a neonatologist and obstetrician, we may see the cord gas with a different lens. And the meaning of the values that we are looking at may be interpreted differently depending if you are a neonatologist and an obstetrician. As neonatologists, as you can see on the left side, we are using it to help our decision when we wanted to screen babies for a hypothermia treatment. But on the other side, the obstetrician will have many concerns when they look at and especially medical legal concerns when they look at the values. However, it's interesting to see here, and it's maybe a little bit small, but I will try to point it out. For the pH itself, the value that are used is quite similar. But for the base deficits values, for example, here in neonatology, we use base excess threshold at 60 millimole per liters. But for obstetrician, they are looking at mainly the 12 millimole per liters for base excess.
No, más
So, yeah, sorry. So, before to go further deeper into the presentation, I will start with two examples. And so you will understand what I wanted to explain to you. So the first case here, I named her Elizabeth. She was born term, and this is the value of the cord gas that we received. Her core pH was 6.94, and the base excess was minus 12.5. And as you look at the cord gas pH, you could be concerned when you look at this cord pH. But this baby had a very good outcome, in fact, and she spent only 3 days in nursery and went home healthy. On the other side of Trista was born also at term, but needed some support at birth and needed some PPV for a few minutes, and had a cord gas of 7.13 and a base excess of minus 14.2. But this baby was not necessarily screened for neurological assessment, and in fact developed seizures at 9 hours of age and was admitted to the ICU and had a more concerning evolution in the hospital. So yes, when we look at the cord gas, we could be concerned. And we could be afraid of the pH because sometimes we got misrouted by this pH. So today, what I wanted to achieve with you is to review what is the normal fetal acid-base physiology at birth, to review and recognize the limitation of the cord gas, the pH and base deficit in determining the risk of brain injury and especially hypoxic ischemic encephalopathy, and to present to you a novel marker for neonatal metabolic acidosis. We call it neonatal Eucapnic pH, and to review how we can better screen newborn who qualify for hypothermia treatment, hopefully in the next future. So first, we'll take a few minutes to talk about the physiology of the acid base at birth and to have everybody to remember the specification of the acid base of the fetus and why the babies are having a maybe different acid base physiology. So here, what I want here it's you have an illustration of what is the oxygenation of the baby. So this is a illustration of the placenta. With here on the bottom side, the fetal capillaries or the fetal circulation, on the upper side, the maternal circulation. But what I wanted to show you here and for us to remember is that the baby are surviving, in fact, in a very low hypoxic, very low oxygenation, hypoxic environment. And in fact, their PO2 is around 18 millimeters of mercury when you compare that to a normal newborn in room air, which is around 80 millimeters of mercury. And so the other thing that we need to remember is that the babies is breathing through the placenta. So the PCO2 is somewhat higher compared to the normal kids or normal adult, and the PCO2 here is around 55 millimeters of mercury, as shown in this picture. So this low hypoxic environment will explain the different metabolism of the baby in utero. And in fact, will explain that there's a different balance between aerobic and anaerobic metabolism in a baby, which make the acid base different than us as an adult. And so what you can see here is that because of the low oxygenation, the anaerobic metabolism is a little bit higher. So there's a little bit more production of H+, which will explain why this baby have a lower pH. And the PCO2 is also increased because of the breathing through breathing through the placenta. And also because of this anaerobic metabolism that is a little bit working at a higher rate, the lactate in babies are somewhat higher than us as an adult. Now, there was some study showing that also that the pH change with time with gestational age, and preterm babies have a higher pH than term babies. And in fact, even at the end of the pregnancy, there's a tendency toward a lowering of the pH over the weeks of gestation. And this is maybe explained by the increasing of PCO2 into the blood of the baby at the end of the gestational age as well. And studies have shown that this also reflected postnatally. And here you have on your left side a study showing the decrease of pH even after birth in the first few minutes of after birth in vigorous babies, where you can see that there's a decrease of pH over the first few minutes of few seconds of life, and associated with increase of PCO2 after first few minutes of life. And what I wanted to show you on the left, on the right side, is also we have to remember that in comparison to adult blood gases, there's a significant proportion of babies that have a very high PCO2 and often above 80 or 90 millimeters of mercury, and that need to be taken into account. And we'll come back to that in a moment. So just to remember, a slide to remember that there's two types of blood gases that we can take in obstetrics and we can use. There's the umbilical venous blood gas, and there's the artery umbilical cord gas. And then we have to remember that the venous umbilical gases represent the oxygenated blood, and it's the blood coming from the placenta. So it helps to assess more the status of the placenta circulation. And on the other side, you have the artery blood gases, which is more the deoxygenated blood, but it represents the fetal status. And that's what we use in clinic in order to assess the acid-base status in a newborn. So there's limitation of the cord gas results. And that need to be taken into account when we analyze when we interpret the cord gas that we receive in clinic. The first thing is that there's challenges with the stats and samples, and these technical challenges doesn't necessarily help when we try to interpret those results. But we have to remember that there's a significant proportion of baby or of the blood gas that we receive that are not in fact taken from the vessels that you think that it was used. And then that's why some of the experts will recommend you do both the venous blood gases and the artery blood gas in order to make sure that you interpret the right gases. But that's not necessarily made in all of the centers. But studies have showed that up to 20% of the blood gas that you receive may not be taken from the right vessels. There's also other technical problems, delays in the analysis or vented sample or it just, in fact, nowadays that we change our practice, the effect of delayed cord, the delay, like the effect of the delayed cord clamping also on the gas results. And also for us here, that what we have with our experience, that the priority is sometimes given to collecting blood from the vessels, from the umbilical vessels for stem cells, and so delay the process to take the blood gases for analysis. There's other factors, clinical factors that influence the values of the cord pH, the parity, the breech mode, the mode of delivery, the breech presentation, the duration of labor, and also many other factors that could influence the cord pH. And then there's normal physiological variation. So if you delay your sampling, for example, and that's what I showed you in the 2 slides prior, that there will be a decrease of pH and increase of PCO2. And there's many like us, we're questioning the validity even of the use of the base deficit in the analysis of the acid-base status of the babies who are born also. So before to go deeper in the analysis of the cord gas results, we have to remember that it's only the pH, PCO2, and PO2 that are directly measured. The other element that we are used, the base excess and the bicarbonates, are all calculated. When you receive a blood gas, we look usually at the cord pH, but we have to remember that the cord pH has 2 components of it. There's the respiratory component and the metabolic component. The respiratory component is more associated with a limited duration of hypoxia, and it's not necessarily linked to cells, lesions, and complications. However, the metabolic acidosis is a more stronger marker, obviously, of the anaerobic metabolism and hypoxia, and is linked to sequela. Classically, we use the base excess as a representative of the metabolic component, and I will come back in a moment to talk more about the base excess. But let's talk about the cord pH and review what is the strength of the evidence of using the cord pH. This is a study that has been published about 10 years ago, and it's a meta-analysis that included 51 articles. And here, just a sample of the tables that they presented in this study, where you see 5 of the 7 study that has been included in this study. When you look at the pH, well, in fact, the first thing that you look in here, that the threshold is used, it's pH less than 7.0, but there was one of the study that is not represented here that used a pH less than 7.15. When you look at the HUD ratio and the risk of, yes, there is a risk, an increased risk of HIE when you look at the cord pH, which is for me quite significant, around 14 times the risk for HIE in those in this study. But if you look at more carefully at the number here of the affected baby, there's a significant portion of these babies that are not necessarily screened with high pH, and this is showing you that there's a high false negative rate in those scores. When you use the cord pH threshold at 7.0, which make the sensitivity at around 60%. And we are concerned about, as an neurologist, about this this high false negative rate or low sensitivity, because we don't want to miss those baby, and we don't want to miss the opportunity to provide hypothermia treatment. So some of the authors explore different threshold of pH, and this is what the study shows here, where they look at a large, they look at in a large cohort, which included about almost 52,000 babies, and they demonstrated that there's an increase in, significant increased risk, even with a pH less than 7.10. So some of the authors will recommend it to use a higher pH, but that could be at the expense of increasing the numbers of baby that you may need to screen. And this is why recently in 2018, I believe that the guidelines, the Canadian guidelines, were modified to include another threshold between pH between 7.01 and 7.15, or the base deficit between -10 and -15.9, in order to with other clinical indicators, in order to decide or not if this baby should be examined and then started on hypothermia treatment. So now, if we look a little bit more in details about the base excess. Base excess, if you remember, it's the amount of base to create the pH at 7.40 with a PCO2 of 40 millimeters of mercury. So basically, you wanted to correct your pH to a normal pH at 7.4 and a normal PCO2 at 40 millimeters mercury, all of that in a normal temperature of 37 degrees Celsius. The interesting part is that the base excess is an ND concept, easy to understand. 0 is your equilibrium. And if you are in a positive value, then you are in respiratory acidosis. If you are in a negative value, you are in a metabolic acidosis. But this is where it started to be complicated. It's when you look at how the base excess is calculated. And now you can realize that there is many ways, many equations, and here you have a sample of 10 different equations to calculate the base excess. And so, and these equations varies between manufacturers of analyzer that you use in the laboratory. And all of them will give you a different result from each other. Now, this has been shown or looked at a little bit more carefully by Mokarami in 2012, where he compared the calculation recommended by the Clinical and Laboratory System Institute, Standard Institute, versus the algorithm of the radiometers analyzer. And it doesn't make a lot of differences, or maybe not clinically important, when you have values which is nearby 0, or here what I may put in circle in the normal range of values for babies at birth. But when you have an asphyxiated baby with a lower base excess, then you started to see a major difference between different ways to calculate. And on your right side, I'll put you an example of what could be the impact. And when you look at the normal baby, or what here in the case 2 with a core pH of 726 and a PCO2 of 54, and you started to calculate the base excess with different algorithm, then the values vary between 2 and 4.2, which is not that so important. But when you look at a baby who is a little bit more in distress with a core pH of 6.91 and a PCO2 at 96, then you started to see some differences, and some very significant differences, because your interpretation could be totally different between the two, some of those values. And so it's a problem. So if I wanted to continue with my demonstration, I just regrouped the equation into few main categories, and here you have 3 categories, but let's concentrate on the base excess in vivo and in vitro. The base excess in vivo is the standard base excess that is used in many of the laboratory that we use, especially here. That's what I've been told here in Ottawa, that this is the one that we use. Now, I wanted to ask you another question, maybe, which is, I guess it is important even for you, is, do you know in your own laboratory, in your own hospital, which one the laboratories use in order to report a base excess? And so I was not knowing it, and so I had to call myself my laboratory. And in fact, when you look at the laboratory results into your EPIC system here in Ottawa, They don't specify which one they use, in fact. And the other thing is, in the literature, it is being recommended to use the standard base excess or the base excess in vivo. But there's some experts that will say, well, maybe it's better to use the base excess in vitro for other reasons. And so there's some confusion about which one we use, and even our guideline doesn't specify which one is used. Now, more importantly, is when you do the calculation, then you realize that these calculations are based on normal adult value and with a pH of 7.4 and a PCO2 40 millimeters of mercury. And if you remember at the beginning of the presentation, when I presented to you the slides, then we realized that the pH of normal baby at birth are totally different with a pH of 729, 728, and a PCO2 around 54 millimeters of mercury. And so that means that when you calculate the base excess and you receive the results of the base excess, there's somewhat of a misinterpretation, miscalculation that going on here. And I wanted to add more about this criticism of the base excess. Not to say that when we, well, I will say here that this is a graph that we created from our own study where we included more than 50,000 babies over a 10 years period, where you show the distribution of, where you see the distribution of PCO2 with the quarter pH here. And what you realize here is that many or a significant proportion of the babies had a very high PCO2. And that's where I go back to what I presented to you about the Copenhagen and the Boston point of view, the debate between the two, is that the calculation of the base excess doesn't take into account this very high PCO2. The Copenhagen school decided to not to incorporate into the base excess calculation the correction for the bicarbonates when you reach these very high level of PCO2. And that is well known that there's an equilibrium of the change of CO2 toward the bicarbonates with the carbohydrate anhydrase into your vessels and into your body, and especially in, well, in vivo, I guess. So all of these reasons will comfort us to recommend it, in fact, that the base excess or the base deficit should not be used in our babies. And there's another concerns about the use of base deficit and the threshold that we are using. What about the quality or the quality of the evidence? And in fact, when you look at most of the publications that use the threshold come from this, well, cited this study that was published in 1997. Well, interesting, this study has been published by one of our colleagues in Kingston in Ontario, Dr. Lowe, who took 174 babies in order to create this table with a different threshold and demonstrate the increased risk of complications in newborn when you have higher base deficit. But this study is a case control study, and when you look at the babies with a higher base deficit, in fact, there are historical cases that has been added into this study. So don't you feel that when you use the base deficit, in fact, you're sailing blindly in the thick fog? And that's what we felt as collaborators when we wrote this article, this provocative article in Journal of Maternal Fetal Medicine just recently, in fact. So yes, we're making good criticism on the base deficit, but we have something in our pocket, is the Eucapnic pH, and this is the markers that we started to look at it a little bit more carefully to see that would help us to better screen these babies with the metabolic acidosis. So to reconcile a little bit what I said here, or to summarize a little bit what I said here, is that the UA core pH is divided by that included both respiratory acids and metabolic acids, and we use clinically currently the basic as a approximation for the metabolic acidosis. But we wanted to propose the Eucapnic pH in order to calculate for this metabolic acidosis. And the Eucapnic pH is calculated, yes, by using the normal newborn values of pH and PCO2, but also it used the normal the simple Anderson-Hasselbalch equations for calculating the bicarbonates, but it adds into the nomogram what is called, what we like the Boston point of view to correct the calculation of bicarbonates based on the level of PCO2, and this is the red line that has been added to the nomogram here in the Charles-Racinet diagram for newborns at birth. So if we take an example, in order for you to understand the way that we calculated first, so here a case of pH with 7.92 with a PCO2 of 100 millimeters of mercury. You plot it onto the nomogram here at 6.92 and PCO2 of 100 millimeters of mercury, and then you make a correction according to this Boston rule, and then you bring it back to normal PCO2 so corrected for normal PCO2 not at 40 but at 54 millimeters of mercury and a pH of 7.28, and you obtain a Eucapnic pH at 7.12. So this is a quick way to calculate, but there's an application that you can use, and it's been available for everyone. It's called the neonatal Eucapnic pH that could help you to optimize these calculations. So now that we have a possible novel markers, we wanted to explore if it is a good marker. So we investigated our new marker, and we put the hypothesis in front that, well, if the neonatal Eucapnic pH is well constructed on a normal newborn acid-base status and take into account the normal pH and normal cold pH, well, it should be a better marker for neonatal metabolic acidosis, and it should better identify newborn at risk of hypoxic ischemic encephalopathy, or should be able to discriminate or identify babies who are depressed at birth. So we started with the first exploratory study where we looked at 30 newborns with umbilical artery core pH less than 7 in a cohort of 5,000 babies born greater than 35 weeks gestation. They were born in a level 1 maternity unit. And we looked at the predictive performance between the UA core pH and the Eucapnic pH for NICU admission. We use the NICU admission as a proxy for depressed newborn. And what we discovered is that the neonatal Eucapnic pH seems to be a better marker than the UA core pH, although but it was like the difference still, if we didn't have a lot of babies and only 4 of the babies of the 30 babies got admitted to an ICU, but still you see that the statistical analysis shows you that it seems to be a better marker. And we calculated the best cutoff Eucapnic pH at 7.11 for this study. So this comforted us to explore a little bit further and go bigger. And so we did a second study looking with a larger population. So we looked at our own data here at TOH and using the 2 satellites, the 2 satellite hospital, the Civic and the General, which has a combined birth rate of over 6,000 births annually. And both of the Civic and the General Hospital has an ICU level. And so we have to remember when we'll go back to the demographic and demographic information that we are following in this center high risk pregnancy as well. So we use the data from different resources, the Canadian Discharge Abstract Database, the TOH Electronic Medical Record System, but the BORN database as well to gather all the information that we needed to have. And so over a 10, and so we did a retrospective cohort study using the ROC curve for 3 groups. I will show you the details and the results. And we look at the cutoff value using the Uden index, and the outcome that we looked at is the predictive performance between the 4 markers for the HIE, so baby with hypoxic ischemic encephalopathy for all stages, and we included the death for the babies who died without any obvious other causes than possible hypoxic event when we didn't have any other diagnosis to explain the death. So we compare 4 markers: the UA core pH, the UA base deficit, the neonatal Eucapnic pH, but we also look at the Blickstein green correction for pH. Some of you will remember that or will know that correction that has been proposed in 2007 by Blickstein and Green, the authors. That's why we put the name here of this article, where they suggested that we should do a correction based on the PCO2 when the PCO2 is above 50 millimeters of mercury. So for each 10 millimeters of mercury of PCO2, we can reduce the pH by 0.08. And that was being proposed by Green and Blickstein. So we have for this study over 50,000 babies. We started with 60,000 babies. We excluded some of the babies, babies with malformation or babies with anything that could impact the acid-base status. And we had to exclude the baby with missing data, which is a significant portion of the data that we have. But we were able to include 51,000 babies in total in this study. You have here demographic information, nothing out of the ordinary. We had a 16% in ICU admission, but remember, we are following, again, a high risk of pregnancy in our center. The UA core pH was 7.21. It's a little bit lower than what is reported in the literature, but we don't have any good reasons in order to explain that. But that's what we observed. But the PCO2 is 53.7 millimeters of mercury, which is comparable to what has been reported in the literature. And the umbilical cord base deficit was around 6.87, which is somewhat higher to compare what is reported in the literature. However, we had 60 cases of HIE and death, including 57 cases of HIE and 5 deaths, but 3 deaths where the baby didn't have necessarily a well-defined diagnosis of HIE, but we decided to include them because that happened just either shortly after birth or in the few hours after birth. So this is the results in the global cohort. So when you look at the 4 markers, you can see that all markers, the UA core pH, the base deficit, and the Eucapnic pH were similar between each other. But the Blickstein one, as proposed by the markers as proposed, or the correction as proposed by Blickstein, was lower. So we decided not to perform any ROC curve for the next steps of the analysis. But these 3 markers seems to be comparable when you put them on the global cohort. But you have to remember that when you look at this cohort, the vast majority, if not the vast majority, I will say, that of those babies, they have normal pH and the outcome is normal for those babies. So that could screw up a little bit and doesn't help to understand how these markers can behave with a higher risk of population. So that's what we did. That's what we did. That's why we did an analysis of the worker with a more high-risk group. So we started with the babies with UA core pH less than 7. And you started somewhat to see a little bit of difference, but it doesn't seem to be that so important for these cohort of high-risk population with babies born with a core pH less than 7.0. However, what was very interesting for us is for the babies who had a borderline pH with a core pH between 7 and 7.15. And that's where we started to see much more differences, where the UA core pH, Eucapnic pH, has a higher rock area under the curve on the rock curve analysis compared to the base deficit and compared to the UA core pH. And especially the UA core pH, as you can see here, it doesn't help you a lot, which is nearby the straight line on the rock curve, which doesn't help you a lot to distinguish between normal babies and babies with HIE as well. What I wanted to comment here is that, yes, the base deficit seems to distinguish somewhat, but not at the level of the Eucapnic pH, but it's still somewhat distinguished or delineate between the babies with HIE and normal babies, because it do some correction, obviously, but not correction to the point that we are able to achieve with the Eucapnic pH. So here, just to present to you that the cutoff value that we calculated is around 7.14, and which, when you use that cutoff value, you have a sensitivity of 88% compared to when you use a core pH of 7.0, the sensitivity is only 69%. So we believe that we could achieve a better screening when we used, or at least in this retrospective analysis, we would have trained better these babies overall by using the Eucapnic pH. Now, the work curve are difficult to conceptualize, and what does that mean in clinical context? And that's why we did a second study, or we did an analysis of all these the 60 neonates that we have in this study, and we looked at the false negative rate when you use the different threshold. And what you observe here is that in this analysis, you can see that when you use the umbilical artery core pH less than 7 and the base deficit greater than 16, the false negative rate is around a third of the 60, of the population that we use. So 31%, 31% is the false negative rate using the core pH as less than 7.0, and 36.7% is when you use a base deficit, compared to the neonatal Eucapnic pH, who missed only 8.3% when you use the threshold at 7.14. Now, when you take the middle population, the borderline pH population, like the baby with a core pH between 7 and 7.14, there was 14 babies. That's where you started to see that the base deficit missed 71% of the babies, compared to only 7.1% of the babies when you use the neonatal Eucapnic pH. So let's take a moment to look at the PCO2 in relation to pH. A previous study have shown that when they looked at the PCO2 and what is the risk of complication associated with high PCO2, and they demonstrated here that when you have a high PCO2, like your risk of complication, hypoxic ischemic encephalopathy, HIE, it increases significantly with the increasing of the PO2, or if you have a PO2 above 80 millimeters of mercury. And this has been reflected in here well, that's another way to present it. When you have a difference between a PCO2 between artery and venous, and the difference is higher, then you have an increased risk as well. But we were questioning this result because we have to interpret the PCO2 in relation to pH. Most of those babies born at birth with a high PCO2, they also presented with mixed acidosis. So PCO2 cannot be interpreted by itself, and that's what we looked at our PCO2 in relations to pH in our big cohort. And this is the cloud that we created for distribution of PCO2, core arterial core PCO2, and compared, well, in relations to core pH. And we also plotted the median and the 95th percentile interquartile range in this population. And we highlighted the 60 cases with HIE in this population. And what you observe here roughly is that the points above, like the points or the numbers of baby above that has a pH, a PCO2 above the mean seems to be much lower than the babies who had a PCO2 below the mean, which is in relation, goes with what we calculate like the metabolic acidosis. And so yes, the frequency of HIE of babies with PCO2 above mean is only 21% compared to the frequency of HIE in babies with a PCO2 below means, which is 78.3%. But more interestingly, you can see here in the babies with borderline PCO2 between 7 and 7.2, all of the babies with HIE had a lower PCO2 or a PCO2 below the mean. And so, but that goes well with the fact that those babies or the babies at higher risk have a metabolic acidosis. So it's interesting. Yes, we got excited. Yes, but yes, obviously there's some limitation by doing retrospective study. Although it was a very big, large database, well, we could question the quality of the data on the primary outcome. And in fact, that's what we observed. We needed to review manually more than 1,000 charts in order to make sure that we didn't miss many of the HIE or making sure that the deaths are not from other causes. You can re-question in this study the quality of the core gas results. And in fact, we didn't have access to the umbilical vein core gases results. So we were not able to necessarily to fully be confident that all the UA core gas that we have were effectively umbilical artery values. We had few gases with PO2 high. We had few gases with very little PCO2 that could also raise concerns about the quality of the results that we were using in our analysis. But this is a miniature of the values that we use, but we still use it. And then there are another concerns is that there was a significant proportion of babies with missing data, which is about 15% that could impact the strength of our conclusion of this study. And especially for those who have HIE and death, there was the proportion of babies that we had missing data was higher. So, but we were still excited by our results, and that comforted us to go a step forward. And so what we wanted to do, and that brings me to the next step, is we would like to explore the impact of using this new marker in a clinic and or at bedside. But we wanted to do it.
Sorry to interrupt. We have about 10 minutes left, so I want some time for questions. So just to give you the perspective, thank you.
Oh yeah, thank you, Joe. I still have maybe a few minutes. So the next step is to proceed with a large multi-centric project to compare false negative rate So we are more interested in false negative cases, obviously, as a neonatologist, and for feasibility as well, because to do a larger cohort study, as you can imagine, you need, because of the incidence of HIE, you need to collect the data on 900 and over 900 cases to get 1 cases of HIE. So that will make a lot of energy in order to be able to do a full prospective cohort study in a prospective manner. So we will concentrate on cases with HIE, and we'll evaluate the impact on the background. We'll not do it directly for now. We propose to do it on like on the background to recalculate all the Eucapnic pH and to retrospectively look at if that will have impacted the screening of the HIE. So we wanted to assess the screening process basically, and here a representation of like an organigram of how we screen for now the for the HIE, and to compare it with a novel way to screen for HIE that include the Eucapnic pH. So on your left side, you have the current organogram of the Canadian Pediatric Society. That is a 2-step process. You have a criteria A and criteria B. So criteria A is your values of the core pH that will, if the baby fit with this criteria B, criteria A, you do the second screen process, which is the neurological examination. And if the baby fit with the criteria B, which is the core pH between 7.01 and 7.015, and an history of perinatal asphyxia event, or in ABGAR scores, or a baby will need prolonged PPV, then you do the second step. And then after the second step, if the baby had an abnormal neurological examination or stage 2 and 3 of HIE, then there's an indication to start a hypothermia treatment. We would like to compare this algorithm to an algorithm that just add the cord, the Eucapnic pH, and we wanted to compare if we are missing less babies with HIE stage 2 compared to the current way to do the screening at the moment, and see if that make a difference between the two. So improving our screening will have an impact, obviously, because when you look at, and so it's very relevant. So we calculated what could be the impact, and the number of babies that may have a neurodevelopmental impairment or cerebral palsy prevented, or that prevented, is maybe not that high in the number, in fact, but when you look at the economic societal cost for an infant with cerebral palsy, which is being demonstrated in the literature around $1 million Canadian dollars, then it started to be much more relevant to improve our screening process. So before to conclude, I just go back to Elizabeth and Tristan that I presented to you, and here I had the PCO2, and when you calculate the new like with the Eucapnic pH for both of those cases, then you realize that, in fact, Tristan here with a PCO2 that was lower would have been identified by our screening for being at risk of HIE, and so would have maybe had the benefit to be examined, and we may have potentially be seeing this baby with some signs of neurological signs, and he would have maybe be started on hypothermia treatment. This is maybe a little bit less obvious for Elizabeth, who had a core pH of 7.14, but you can see that the PCO2, the high PCO2 shows you that the metabolic acidosis proportion was lower, and this is well reflected by the Eucapnic pH here. So some take-home messages, and that will conclude my presentation, is that yes, we have to remember that the fetal acid-base physiology is distinctive from the adult or the kids acid-base physiology, and that should be taken into account when we calculate and when we try to estimate the metabolic acidosis. UA core pH has some prediction, but is somewhat limited because it includes the metabolic and the respiratory portion of the acidosis, and we recommend that the base deficit should not be used for the reasons that I exposes to you. And we are proposing this new Eucapnic pH in order to assess the metabolic acidosis, because it's based on physiological principle, and also because the results from our prospective studies seems to be promising, but that need to be comforted in a prospective manner. So I wanted to especially thank all my collaborators, that all of these people that I contacted, and they expressed their strong interest to participate to this prospective study. We are in the process to look at for funds in order to help to complete this big, interesting project. So thank you. This is my last slides. Thank you, Joe. I'll give it back to you, but I'm happy to take questions.
Thank you, Dr. Daboval, for a very thorough review of the acid-base physiology of the neonate. I wanted to first ask a question. While you were talking, I looked on my phone and to see if there were any apps that do this. I can't imagine people trying to find the normograms with each pH having its own line, etc. And I noticed there are already some apps to look at Eucapnic pH. Have any of these been validated, do you know? And is there one you recommend to the house staff, or do you think it's still very much still in the phase that's being worked out?
Yeah, so I think we didn't publicize it because we wanted to have a better evidence to use the neonatal Eucapnic pH. And so yes, there's a Eucapnic pH, which is and I'm not sure if I don't know, I didn't explore the apps for that, but Eucapnic pH is being recognized and it's been described many years ago. But it made the correction for PCO2 of 40 millimeters of mercury. So we have to be specific in using the neonatal Eucapnic pH. So there's an app, which I didn't Google it recently, but there's an app called neonatal Eucapnic pH. So, but this one you need to use. This is the one that has been developed by one of the collaborators of Paul. And it made it available by him in order for us to be able to use it. But what we would like to do, in fact, is to go a step further and then convince the analyzer to add this algorithm into their machine, so we can have it really available at the bedside for our babies. And so not to make this calculation manually, but more to included into that will be our dream for the team, to include it into the machine themselves, and so we can use it at the bedside.
Thanks, Thierry. I see a question from Sharon Coffey in the chat. If the algorithm is validated, can it be applied retroactively to previous results?
Oh yes, yeah. Well, do you mean from a research point of view? Or is that what Sharon was referring to?
I'll ask Sharon to unmute herself and continue.
That's what I'm assuming. But yes, we could take big, large database if we have the cord pH and the PCO2. So I did explore that with the Canadian Neonatal Network, but in fact, and I think it's maybe the way that we are influenced, the way that we are thinking, even in the Canadian Neonatal Network, the PCO2 is not recorded. So we don't have access. I did contacted the Canadian Cerebral Palsy Network, same thing. They have the pH, they have the base deficit or the base excess, but they don't have the PCO2. So, I mean, even us as because of the guidelines, maybe influences strongly with the guidelines, that says you have to look at the pH, the base deficit. We don't look at the PCO2, but many of us as neonatologists has the experience. When you have a baby born with a PCO2 at 120, then you are okay. Well, okay, that's fine. It's the respiratory acidosis. We're in a better spot. But we are not necessarily, it's not automatized that we have to look at the PC2 and be very careful with the PC2 in order to interpret these gases. And then we are so much automatized in our way to look at the cord gas that we just look at the base deficit. And then we said, okay, this is the metabolic acidosis, which is, as I showed you, totally mistaken. Misrouted.
Thanks for clarifying that. Thierry, we're now a little past 9:30, and so we have to bring the meeting to a close. I want to thank you. Perhaps after the meeting, if people have specific questions, if any of the residents or trainees have questions, I would encourage you to contact Thierry and take your questions offline. Dr. Daboval, thank you for a fascinating presentation and renewing our interest in the neonatal physiology.
Thank you,
Thank
Joe.
you, everyone,
Thank
for
you, everyone.
participating. Of note, we had over 100 participants this morning. At one point, we were 102 participants, which is pretty impressive. So thank everybody for participating in Grand Rounds at GEO this morning. And with that, I'll draw the meeting to a close. Thank you.
Thank you. Thank you.